enzymes that is known in the literature. And because of that induction, two things will happen. Well, one thing will happen, and that is any other drug metabolized by the liver is going to be cleared more rapidly. We'll come back to that in just a couple minutes. We're going to refer to it. And if I use the term induction, does everybody know what that means? Induction of drug metabolizing enzymes? Okay, so I'm going to use the term induction to refer to induction of cytochrome P450 drug metabolizing enzymes. Did I see a question?
I had a question. Because my dog is on phenobarb, and I was thinking, what role does the preventative medicines that we give monthly play on the interaction with phenobarb?
So why don't we come up and talk about that during the break? Because I just need to understand your question a little bit better.
Okay.
Okay. All right. It's a good question. I just want to make sure I understand. And I want to get through this. All right. So phenobarb. We've already talked about the long half-life, variable metabolism. But I want you to understand that this 48 hours that we're going to agree on as our half-life of phenobarbital is markedly variable. It is, and I'm going to say disastrously variable in some animals. For example, if an animal's on phenobarbital and the half-life is 48 hours, what's going to happen to the half-life because of the phenobarbital itself? It will decrease. Phenobarbital is going to auto-induce. It's going to turn on the liver, and its own metabolism is going to increase, and the half-life can get very short. We've seen half-lives go from 48 hours to 12 hours in a dog on phenobarbital. And that means the dog goes from accumulation to fluctuation. Is that making sense? So that's part of the reason we always want trough concentrations, because we don't know what that half-life is going to be. The cat does have the longest half-life. The horse, interestingly, has the shortest half-life. But still, it's a drug that we won't use that much because we don't deal with seizuring adult horses anyway. All right, so here's the drug interactions. Any drug that the animal is on that is metabolized by the liver, just assume that it's going to be metabolized more rapidly. Now, if metabolism inactivates the drug, then the drug's not going to work as long. But remember that metabolism may also produce active metabolites, which means that more active drug may be formed. And finally, and maybe disastrously, if the drug, this other drug, not phenobarbital, but if the other drug that's being given with phenobarbital that is metabolized by the liver is metabolized to toxic metabolites, what's going to happen in a patient on phenobarbital? We're going to have more toxic metabolites formed, and that means a greater risk of adversity. So understanding the sequela of induction of drug metabolizing enzymes with phenobarbital means you need to understand the other drug. What happens when you metabolize the other drug. And it's part of the reason I say try to avoid adding other drugs metabolized by the liver in a patient that's on phenobarbital. Or, if I have an animal that's on lots of drugs, I'm going to try real hard to use bromide instead, because bromide does not have to be metabolized by the liver. And that way I don't have to worry about it at all. Go ahead.
I was going to say, that's kind of the question I had that I was asking. I wanted to know, like, what does Comfortis do, or...
So that's, again, that's something that we can't talk about now. I just don't have the time, but you are asking the right question. If your patient is on, your pet is on another drug metabolized by the liver, and it's on phenobarbital, you need to step back and make sure that that increased metabolism by the liver is not going to put your patient in harm's way because of that other drug.
Okay, thank you.
Good question. All right. Now, the other thing that we're going to see is phenobarbital induces serum alkaline phosphatase. Now, what's serum alkaline phosphatase? What organ does it reflect? The liver. So this is turning it on. It has nothing to do with liver disease. It is turning it on, just like glucocorticoids will do. We'll talk about glucocorticoids a little bit later in the semester. And this is one of your challenges. If you do blood work in a patient that's on phenobarbital, you're going to see that serum alkaline phosphatase go up, and you're going to be thinking liver disease, and it probably is not liver disease. It's probably just induction. How would I know if it's liver disease? Yeah, we're going to look at the rest of the blood work. We're going to look at the SALT, if it's increased, if the bile acids are up, if the albumin is down, if the blood urea nitrogen is down. Those are all indicators that the liver is sick, and yep, phenobarbital might be doing it. But we can't just look at the serum alkaline phosphatase because that is induced along with the drug metabolizing enzymes. Is that making sense? And this is very real. You will see this in animals that are on phenobarbital. Now the last point about this is phenobarbital is metabolized by the liver. If you use other drugs that inhibit the liver, phenobarbital is going to be hit. Now what do I mean by that? Do you remember any drugs that Dr. Judd told you that inhibit drug metabolizing enzymes? Chloramphenicol was one of them. Potent inhibitor of drug metabolizing enzymes. All of the imidazole antifungals, ketoconazole, fluconazole, itraconazole, they all potently inhibit the liver. If you use them in a patient that's on phenobarbital, what's going to happen to phenobarbital clearance? Is it going to go up or down? Down. And what's going to happen to phenobarbital concentrations? It's going to go up. And what's going to potentially happen in the liver? Potentially increased risk of toxicity. So you have to pay attention to other drugs that you're using in a patient on phenobarbital. Okay. So for Bo here, remember he comes to us because he's having refractory, not refractory, but he is having breakthrough seizures. He was well controlled for a year, and now he's having breakthrough seizures. His baseline, his startup phenobarbital concentrations were 25. The first question I'm going to ask is what has happened to his phenobarbital concentrations? And the answer is they have dropped. They're now down to 15. So Bo's therapeutic range for phenobarbital is 25. When he drops below them, he seizures. Look at his half-life. It's gone from 70 hours, which was his initial half-life. Remember I told you 48 is our working half-life, but it's quite variable. And it went down to 20 hours. So his drug concentrations have dropped because of autoinduction. What do we do for Bo? Increase his dose, get his drug concentrations back up to about 25 or 30. Now when we do that, his liver is probably going to induce again because every time we up the dose, it'll probably induce again. But we're going to monitor him and make sure we get those drug concentrations up to about 35, 30 to 30, well 30, 25 to 30. Is that making sense? If his drug concentrations were 25 or 30, then I would say his disease is getting worse and he's probably developed tolerance. Is that making sense?
Can you repeat that?
So if we measured him here and instead of being 19, his concentrations were 25 or 30, then I would say he's probably developed tolerance because he is seizuring now, he wasn't before, his drug concentrations are the same or higher than they were before. So tolerance and disease getting worse are basically the same thing, at least as far as what you do. You could still up the dose, but now you're increasing his risk of toxicity. Is that making sense? Okay. So for Bo, no sense going to another drug. Let's just up his dose. We should be able to do that safely. So this is a dog liver from one that had sustained phenobarbital-induced hepatotoxicity. The hepatotoxicity is a type A. Type 1, remember, it's predictable. It's related to dose and exposure, drug concentrations. Maybe an increased risk with induction simply because we're making more toxic metabolites. You're putting more phenobarbital into the patient. So I think that there probably is an increased risk. And we've already talked about how to discriminate it from simple induction. Look at your other liver tests, not just serum alkaline phosphatase. Now, if you see this, if you see liver, not the liver, once you see that, it's out of the dog, and nothing you can do there. But if you catch the liver disease, and you stop the phenobarbital early enough, you can actually buy this animal a lot of time. And the story I have is a dog that had this kind of, it looked like end-stage liver disease, hepatic encephalopathy due to phenobarbital. Got her off of phenobarbital, put her on bromide, and she lived her another 4 to 5 years. So if you can stop the exposure and treat the liver, then it's impressive what you can get these animals to do. You guys know Sammy and silymarin as hepatoprotectants? Has anybody talked to you about using them to protect the liver?
No.
Okay, so let's go ahead and put an asterisk by here. Sammy, silymarin, milk thistle. If you guys know milk thistle, those are hepatoprotectants. If you have an acute hepatopathy, anybody talk to you about using, treating acetaminophen toxicosis with mucomist? Okay. Same thing. If you have an acute hepatopathy with phenobarbital, any acute hepatopathy caused by a drug. use Mucomist. It does the same thing. It gets glutathione in the liver, and that helps the liver scavenge oxygen radicals. Okay, yes, ma'am?
Why is there a decrease in albumin and BUN?
Sorry.
That's okay.
Not an increase in albumin.
I'm sorry,
I'll turn
decrease.
that off here in just a couple seconds. A decrease in
Yeah.
albumin and a decrease in BUN. Is that making sense?
Why?
So the decrease in BUN is because, remember, the liver makes BUN. And yeah, it goes up with renal disease because the kidney can't get rid of it, but the liver has to make it. And so it will go down with liver disease. Does that make sense? Let me turn this phone off, sorry.
She didn't answer my albumin question.
I do not know why I was doing that. All right,
And albumin?
pardon?
And albumin?
So the liver makes albumin, so it will go down,
Okay.
okay? All right, so, and I want you to notice this slide, I've only got it here for phenobarbital, but there is an increased risk of pancreatitis, we think, in animals that are on anticonvulsants, we think, I say we think. And some papers say it's just bromide, but it's not. It's phenobarbital and sometimes the combination. So while this slide is here for phenobarbital, it applies to bromide as well. That is one of the potential side effects. And I think part of the reason for this is these dogs are eating like crazy. They're eating like crazy on bromide, they're eating like crazy on phenobarb. And we're going to see that here when we get to adverse effects. So that is one of the risks that we're going to have to worry about. The biggest, of course, is hepatotoxicity. So let's look at some other side effects. So first of all of these anticonvulsants are sedating. The whole point of them is to suppress the neurons. And so sedation and clinical signs of sedation, whether it's ataxia or grogginess, are all side effects of most of these anticonvulsants, some worse than others, and phenobarbital ranks right up there. Now the body tends to develop tolerance to those side effects, and so that's what this is down here, generally within 1 to 2 weeks. On top of that, polyphagia, the 3 Ps, polyphagia, polydipsia, and polyuria. They eat like crazy. For whatever reason we are stimulating the appetite. They will gain weight. You need to tell the client you're going to have to watch their diets. The polyuria, probably because they're drinking more. Although there's probably some direct effects in the kidney. And they're drinking more, again, because of the CNS effects. For whatever reason, at least phenobarbital tells the body to drink water. So these aren't lethal, but they're things you've got to warn the client about because they're going to get mad. If you don't tell them that their dog's going to urinate more, because they can start having accidents in bed because they are drinking so much. So just warn them about that. All right, so the last one is something that's unique to phenobarbital, and it happens, I think, with any drug that can be metabolized by the liver, because I think it's probably an active metabolite, and that's bone marrow suppression. And it generally is a pancytopenia, but you usually see it because of the leukopenia. Usually what happens is the animals develop a fever because they're neutropenic. And so what you will, and I call it, it's I've got in parentheses allergic. I don't know that it's an allergic, but it is a type B reaction. Very few animals develop it. And you will know because the animal's been doing fine, but if you have an animal on phenobarbital and it presents with a fever, measure the white blood cell count. And if it's bottomed out, you need to get that dog off of phenobarbital in a jiffy. It may also be thrombocytopenia, but it's general bone marrow suppression. And remember, it generally does require about 10 to 14 days of exposure, but remember, it can show up 3 years after being put on phenobarbital. But there generally has to be at least a long enough time for an antibody to be generated. Okay, so the preparations, and notice that they're all Schedule 4. This is also a drug that comes in grains, right here, half grain. 65 milligrams is a grain, but nicely, they go ahead and put the milligrams on there as well. This is a very, very old drug back when we were administering things in grains, and so they just have kept that on the label. There is an IV solution for status epilepticus. And there is an oral solution intended for children, but it's good for the dinky dogs. We use those for the Malamutes and the Yorkies and the Chihuahuas. And the nice thing about phenobarbital is because its oral bioavailability is 100%, I can go from an IV dose to an oral dose. I don't have to change it. And that's nice if you're transitioning from status epilepticus to maintenance control. So when we look at the role of phenobarbital, the clinical use is it's largely chronic, first choice chronic for all species, including probably exotics. Monitoring should be used. Steady state takes about 2 weeks, and so you can generally see about 80% efficacy if you use monitoring to guide your therapy in dogs. So it can be a very effective anticonvulsant. For status epilepticus, it's a second choice drug, maybe third choice, depending upon your clinicians. Remember, to get them up to therapeutic concentrations, you're going to have to give a pretty hefty loading dose. And remember, it will take a little bit longer to get into the CSF, and so you're going to want to administer in increments. Maybe give a third of the dose and then wait 10 minutes and then give the next third of the dose that you've calculated. Okay. So diazepam joins phenobarbital as far as targeting GABAergic receptors. This is both in the brain and the spinal cord. And one of the neat things about diazepam, and one of the reasons that we should use benzodiazepines in general to treat status, is right here. Depressed spinal reflexes. So while diazepam is not particularly good at inhibiting the focus and the initiation, it does decrease the spread of seizures, and because it's in the spinal cord, it also acts as a muscle relaxant. And of those of you that have unobstructed tomcats may know that. We use diazepam sometimes to relax that urinary sphincter muscle. So that's a good thing, because if we have an animal in status, not only can we potentially have CNS effects and stop the seizure, but if we have skeletal muscle relaxation, that helps prevent the hyperthermia that can be killing these animals as well. So I think that's one of the reasons that diazepam is, or benzodiazepines in general, are first choice anti-epileptics for emergency situations. I told you can't use it chronically. 2 reasons. In the dog, they develop tolerance. Every benzodiazepine, save maybe chlorazepine, dogs will develop tolerance. The drug just stops working, and so we cannot use this drug long term. You can send it home in a syringe to give for a client to give it in an emergency situation, but if you use this drug every day, dogs will develop tolerance to it. So we'll talk about the other reason here in cats in just a couple minutes. Now, diazepam is actually well absorbed orally. You can actually use it orally if you wanted to prevent seizures in an animal that looks like it's about to have a seizure, but it has a very short half-life. Now, the nice thing is, however, it does get metabolized to active metabolites. And in fact, the active metabolites, when you put them all together, probably have more efficacy than does diazepam. So that's a good thing. That helps it work, even if you give it orally and it is metabolized very rapidly. In fact, it does undergo first-pass metabolism with oral administration. So for IV, the active metabolites, of course, also will be produced. And the nice thing about that is we transition to a half-life of about 3.5 hours when you put everything together, when you put the active metabolites and the parent compound together. So that's kind of good. Still may be too short. If you're presented in an animal with status epilepticus, a half-life of 3.5 hours may be too short. And so generally what will need to happen is put up a constant rate infusion. So the animal will respond, and then suddenly it'll start seizuring again maybe half an hour later. That's a key that you probably need to set up a constant rate infusion because of the short half-life. So we do have preparations, again, IV and oral. The oral is not particularly useful for us. It's actually misleading. People might think that you use it for long-term management. I have alprazolam down here, but midazolam would be another drug to put down there. So there are multiple benzodiazepines. Do you guys remember when we talked about alprazolam? I just mentioned it very briefly. Where does alprazolam show up? Does anybody know? We use it to treat anxiety in dogs, so it's a behavior-modifying drug. And benzodiazepines are very good at treating anxiety. That is why they are abused by people, and that is why this is a Schedule IV substance, because they're very good anxiolytic drugs. So, here's the other reason we can't use diazepam long-term. You can't use it long-term in cats because it causes hepatotoxicity. Doesn't cause hepatotoxicity in dogs, but it does cause hepatotoxicity in cats. It's probably idiosyncratic, maybe related to allergies, we don't know, but it's lethal. If cats develop diazepam-induced hepatotoxicity, that cat is probably going to die. So, emergency management, that's its primary role, is emergency management, and this is a drug that you probably can give rectally. Send home with the client in a syringe, and they can try and give rectally or nasally if they can't get to the emergency clinic in a rapid time frame. Okay. So the third anticonvulsant is potassium bromide. This is not a drug, not an official drug. When the FDA started approving drugs and they looked at the list of drugs that they wanted to approve or couldn't call drugs, phenobarbital was around and they didn't think they needed bromide anymore, and so it didn't make the cut. And so we have used bromide as a compounded preparation for many years. Now, there is this preparation, K-Brovet. It actually is manufactured. It's not an approved drug. It's undergoing approval, we hope. But it probably, in my mind, would be the preferred drug, the preferred preparation, just because it does follow good quality assurance. So how many of you know K-Brovet? Have you seen K-Brovet? Okay. Most of the time, I'm guessing most veterinarians may actually just have potassium bromide compounded. And this is something that you can compound in your office as well. There are multiple salts of bromide. Bromide is the active ingredient. We don't really know how it works, but there is a sodium bromide and a potassium bromide. Most of the time, veterinarians use potassium bromide. If you use sodium bromide, there's a little bit more bromide in the sodium salt, and so you'll want to adjust your dose, but the reality is you'll use monitoring anyway, and so that probably becomes not as important. So because its mechanism of action seems to be complementary to other anticonvulsants, we tend to use it in combination with other anticonvulsants. And so it's a good drug to add on. And that's how we started using this